Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Neurocognitive Functioning of Children Treated for High-Risk B Acute Lymphoblastic Leukemia, Randomized to Capizzi versus High-Dose Methotrexate, a report from the Children's Oncology Group by Hardy et al. My name is Brenda Spiegler, and I am an Associate Professor in the Faculty of Medicine at the University of Toronto and the Director of Psychology at the Hospital for Sick Children in Toronto, Canada. I am a pediatric neuropsychologist in the Division of Hematology Oncology, and my oncologic specialty is acute lymphoblastic leukemia. The high survival rate in childhood cancer is one of the greatest success stories in medicine, as survival now approaches 90% for many forms of pediatric malignancy. Acute lymphoblastic leukemia, referred to hereafter as ALL, in particular has been transformed from a uniformly fatal disease in the 1950s and 60s to a largely curable condition today. In that context, attention is turned to the quality of survival, with neuropsychological outcomes being of special interest and concern. Effective treatment for ALL has radically changed over the years in response in part to neuropsychological outcome studies that revealed cognitive declines in children treated with cranial radiation. Whereas 2400 centigrade was the norm in the early 1990s, the dose of radiation was reduced first to 1800 and then 1200 centigrade as research studies continued to demonstrate neurocognitive declines and associated learning problems that were greater in girls and in children treated at younger ages. As a result, the current standard is to treat children without the use of cranial radiation, using chemotherapy-only protocols. While survival remains very high and the neuropsychological outcomes are better, some children continue to experience neuropsychological and psychosocial impairment, making it important to understand which treatment, host, and environmental factors predict these negative outcomes that affect quality of life after treatment for childhood cancer. Methotrexate and corticosteroids are both core components of treatment for pediatric ALL. The Children's Oncology Group AALL0232 trial showed that treatment with high-dose methotrexate led to a higher rate of 5-year event-free survival compared to escalating dose methotrexate, and that the combination of dexamethasone and high-dose methotrexate led to superior outcomes compared to other combinations of treatment agents. Because prior studies have implicated methotrexate dose and route of administration as being related to neurocognitive outcome, and because corticosteroids are known to affect brain structure and function, these two agents were selected for randomization. In this context, the Hardy et al. Study that is the subject of this podcast contributes important information about the three important factors of treatment: host and environment on outcome. In this context, the Hardy et al. Study that is the subject of this podcast contributes important information about the three important factors of treatment, host, and environment on outcome. They report cognitive and neuropsychological outcome data from 191 children between the ages of 1 and 18 at diagnosis who were treated with chemotherapy for high-risk B lineage ALL, and were randomized to receive either high-dose intravenous methotrexate with leucovorin rescue or escalating dose methotrexate with PEG asparaginase. The subset of 88 survivors who were under the age of 10 at diagnosis were also randomized to either prednisone or dexamethasone as steroid therapy. The subset of 88 patients who were under the age of 10 at diagnosis were also randomized to either prednisone or dexamethasone as steroid therapy. An important strength of this study is that the agents were randomized against the background of a common therapeutic trial, AALL0232, so that many other factors were held constant. Neuropsychological screening of IQ, working memory, and processing speed was administered 8 to 24 months after completion of active treatment. These domains were selected because they have been shown repeatedly to be sensitive to treatment for childhood ALL. Treatment factors were the main variables of interest. After controlling for host and environmental factors, neither methotrexate nor steroid randomization nor their interaction was associated with declines in estimated IQ, processing speed, or working memory. However, there was some evidence to suggest that both host and environmental factors may have affected outcome. With respect to host factors, none of gender, ethnicity, or race were associated with neurocognitive outcomes. However, regardless of treatment arm, age at diagnosis, specifically being under age 10 at diagnosis, was associated with lower IQ and processing speed scores compared to patients older than 10 at diagnosis. Although the authors acknowledged that the sample size was underpowered for a genome-wide association analysis, they nevertheless explored the association between germline host polymorphisms and neuropsychological outcomes as an exploratory aim. Perhaps because of being underpowered, no germline single nucleotide polymorphisms were associated with estimated IQ or processing speed in this sample. And finally, the authors used insurance status as a proxy for socioeconomic status, which can be considered an environmental or social factor, which is known to be significantly associated with IQ in the typically developing pediatric population. In this study, insurance status was significantly associated with post-treatment IQ and working memory. Those children covered by public insurance had significantly lower scores in both domains. The Children's Oncology Group AALL0232 trial demonstrated a difference in event-free survival between the combinations of chemotherapy agents, doses, and methods of administration studied here. So it is particularly important to demonstrate comparable neurocognitive outcomes. But as a cross-sectional design, the study cannot address change over time. It is one thing to find no difference between treatment groups, and that is an important finding. But that does not mean that there's no decline related to the treatments administered, only that the treatment groups did not differ from each other. So it is important that the COG has funded an ongoing, longitudinal, computer-based assessment of neurocognitive functioning of patients enrolled on the current COG therapeutic trial for children diagnosed with high-risk BALL, which is called AALL1131, with the aim of documenting the onset and course of neurocognitive decline in this population. If we know that a proportion of survivors of childhood ALL will have long-term effects on cognition and learning, it is important to know which factors or combination of factors predict these negative outcomes. Because combination chemotherapy has a weaker effect on neuropsychological impairment than cranial radiation, we must consider multiple factors if we are to successfully predict risk for individual patients so that early interventions may be offered. With the exception of age and gender, host and environmental or social factors have received relatively little attention as predictors of outcome in children treated for ALL. The concept of cognitive reserve, which is represented by both host factors such as genetics and environmental factors such as socioeconomic status and enriched experiences, is important to consider in our model. In 2010, Kessler et al. Reported that maternal education was positively correlated with working and verbal memory in survivors of ALL. And Jansen et al. Document a greater than 20% incidence of atypical development in children with newly diagnosed ALL that could potentially make them more vulnerable to neuropsychological late effects following treatment. Hardy et al.'s finding that public insurance as a proxy for socioeconomic status is related to neuropsychological outcome adds to the information about vulnerabilities related to host and environment. It will be especially important to study this population longitudinally if we are to consider the double hit hypothesis that children from socioeconomically disadvantaged homes or those with premorbid developmental vulnerabilities may be at an increased risk of neurocognitive decline following treatment for ALL, as this would have an important implication for early intervention. A second concept that generally has not been considered in research on outcomes after treatment for ALL is adverse childhood experiences, or ACEs. There is a substantial literature showing that forms of early adversity, such as abuse and neglect, substantially increase a child's risk for negative physical, emotional, and behavioral outcomes as adults. Could treatment for childhood cancer be considered a form of early adversity? The Hardy et al. Study demonstrates that late effects on neuropsychological function are not likely to be due to one factor alone. Going forward, it will be especially important to consider multiple factors that incorporate treatment, host, and environment or early experience, and their interactions as we continue to try to predict which children are at heightened risk for negative outcomes. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.